Thank you, Jason. That was a wonderful video. You could call that my memory video for my last 18 months involved in COVID operations. Minister Masagos, colleagues, friends, and my wonderful teammates from IHiS, good morning. Thank you for joining this HealthTech event. Despite this being my sixth keynote in this event, I actually have some difficulties putting this keynote together. And the main reason is about fresh content. There's only so much we can actually talk about pop health strategies and technologies, especially to this level of audience. Ultimately, it's about implementation, and in healthcare, speed of implementation is not really our defining characteristic, except when in pandemic situations. So we are known to actually evolve rather than transform. And our evolution has slowed last year, but I'm really glad MOH and healthcare leaders are making a very determined effort this year to strongly pursue a population health agenda despite the COVID situation. We actually now have 3 day jobs. There's COVID, we also have our current healthcare business, and our future healthcare business, actually. So dedication of folks working in healthcare and HealthTech is quite unmatched. Given our relatively slow progress on pop health, I've decided to focus on recapping what it entails to lay the technology foundation for pop health, where we are, and a frank opinion on our gaps. I hope to convince everyone that we actually have a decent technology and data foundation that we can build on. And I hope we can get on the same page on what else we need to do going forward. Pop health is about improving a number of things: physical and mental health outcomes, well-being and access for vulnerable groups. So it's about health outcomes for our residents, not just in medical and health administrators' terms, but also in patients' definition of what outcome means. It's also about shifting beyond treatment to disease prevention and management, and it's providing access to those who need help. And how do we do so? We will look at wider determinants of health, including lifestyle, social, economics, cultural, and environmental factors. And public health would need to work across the entire healthcare sector with communities and social agencies, and basically any party who could help improve the wider determinants of health for our residents. Conceptually, it flips from a model of a citizen needing to understand how the various stakeholders work to stakeholders working together now to understand what the citizen needs. And I think pop health will also require collaboration and information exchange, service integration, and administrations across population health actors. Evidently, this is actually a paradigm shift, and the journey will be long and complex. The new care model will evolve on the foundation of some building blocks. This includes healthcare financing, primary care transformation, and improving access to high-quality long-term care in the community. And MOH and public healthcare leaders have also identified tech and data to be a key building block of pop health. In fact, I would argue that without tech, pop health is actually impossible. Why is that so? We only need to understand some of the key differences between now and the future healthcare. I think pop health is about enabling the population to achieve better outcomes for themselves. It's enabling themselves. So it's about empowerment, information, access to help, and convenience. So we need tech and data for that. It's also about looking out for the population who may not be our active patients yet. IHiS will require data to understand the population. Pop health is a team sport with citizens at the center. We need patient-centric information. We need tech to enable team sharing and teamwork. And at its best, pop health is about continuous engagement with patients on their determinants and indicators of health. The intent is to intervene early to prevent chronic disease or episodic care. So continuous engagement is not sustainable without pervasive and convenient technologies in the hands of citizens. Pop health is also about influencing patients to adopt health-seeking behaviors based on understanding of their motivations and challenges. It's also about helping care teams to adopt different programs for different patients. On the extreme, technology and data can help support a care model at the size of one citizen versus a one-size-fits-all care model. And pop health is also about care and engagement at patients' place of convenience and not necessarily at a healthcare institution. Tech is essential to enabling remote care. So IHiS believes there are 4 major streams of work to establish a tech and data foundation to support those shifts. Let me explain this as a whole before diving into each stream. I think firstly, we must have a digitalized population health. Firstly, we must digitalize our population health providers and actors. With a digital backend, we can then facilitate the exchange of data and integration of services between the different population health actors. Integration across these points is possible on the foundation of point digitalization. And based on the data obtained through our integration channels, we contextualize the needs and programs for our citizens. We can also evaluate the effectiveness of a model based on the data that's being exchanged. Finally, with a well-digitalized healthcare institutions, an architecture that integrates across all pop health actors, a personalization engine, we can then engage the population more effectively with a digital-first approach. So let me further elaborate what each means and the status of each workstream. Digitalization. The software should support patient-centric care. And I think over here there are 2 aspects. One is helping the care team to know who has done what to the citizens. And number 2, knowing what's the citizen's health state based on continuous engagement. So these are the software features that are required for the care teams. And all pop health actors need to be digitally enabled for pop health to be sustainable. Again, there are 2 aspects here. The apparent part is to provide technology features which enable actors to perform their role. But what may be less apparent is also the need for the population health actors, including care providers, to contribute information for team-based care and patient empowerment. And the features we need will have to also go beyond textbook EMR. I'll come to that in a moment. One of the most useful products which supports patient-centric care is the National Electronic Health Record, NEHR. This is a screenshot of 61-year-old patient Lim Mei Man, who has a series of episodes across services, across public and private sector, and across care settings from primary care to long-term care. This view gives the care team an understanding of who has done what with her across healthcare. It is patient-centric. But before you start feeling sorry for her, she's just a mock-up patient. NEHR also provides the users, especially the doctors, with customizable dashboards on what pertinent information they wish to see regarding the patient. This user prefers to have the view defaulted to patient meds and investigations. Medical alerts such as allergies and COVID are also displayed. And over the years, the NEHR data set has enriched for care and administration. It has the potential to be a crucial system for continuum of care and care coordination. And information is actually very updated as contributions are made soon after the occurrence of events. The system currently supports more than 1.2 million patient searches per month, and it has almost 20,000 users. This makes it one of the most heavily used HealthTech products in Singapore. It is used extensively and supports patient centricity. This should be a key system to support population health. But there are gaps within the digitization gaps within the healthcare sectors. Healthcare providers need to digitize their clinical business, not just digitize the administration of the business. So we have to digitize the clinical business. There is a need for EMR, NHR access, and contribution. Currently, public healthcare has very high level of digitization and NHR contribution, but we need the private and VWOs to level up. So software features within the systems should go beyond EMR. On this aspect, even the public healthcare IT systems need to be enhanced with pop health features. This includes risk profiles, patient risk profiles, decision support, patient outcomes and experience measures, care team coordination features, and telehealth. The system should also provide features to integrate care and support workflow across care teams. The gap here actually is less on technology, but more on the design of integrated services across pop health actors. And finally, systems need to be enhanced for population health administration. So that was digitalization, right? But digitalization is necessary but insufficient to support pop health. We need to support an integrated care model, and we need data to flow for shared care and population health administration. And right now, I think we are short of clarity of the care model, and we have constraints on data sharing. The good news is we already have some capabilities to exchange data and for systems to talk to one another. Across public healthcare, across public and private, across healthcare to MOH, MOH to other government agencies. So we're able to actually exchange and for systems to talk to each other across all these settings. And this is possible with a decent library of APIs and integration points that were developed over the years. This was actually proven in COVID. So a vaccination appointment to Health Hub flow involves 5 systems, 6 systems if it goes to trace together. And the data flows almost real time. An appointment made now instantly shows up in the registration systems in the vac center. The vaccination administrations, which I just had my booster jab over the weekend, shows up in Health Hub within seconds. Most patients can see their vaccination records while waiting at the observation area of the vac centers. We got these systems to talk. We got these systems to talk to one another within days. We have seen that same capability for COVID test results and patient risk profile portals. We have the technical foundation and expertise to actually integrate systems. But occasionally I heard comments about siloed systems that cannot integrate. It is true that many things don't integrate, but it is wrongly attributed to siloed systems, in my opinion. Siloed systems by itself are not a problem if it can technically talk to one another. And many of our systems can actually talk to one another. Several siloed systems can even form an impressive best-of-breed solution. So what caused our integration problems? In my opinion, the biggest issue we have is the clarity of care model and use cases. This also involves the question of what data to pass across population health actors. Take GP referral to SOC as an example. The crucial issue here is about demand and supply management of SOC slots, and less on the design of app or exchange between GPs and SOC systems. Our data sharing policy and laws have impeded proactive care and shared care. Some providers also have quality issues in their digitalizations. So I think these are the 3 major gaps in integration: the care model use cases, the data sharing, and point digitalization issues. So beyond digitalize, so what do we do after digitalize and integrating systems? Next is about contextualization of the data that we obtain through integration. If you want to change someone's behavior, it is best you understand the person's context, motivations, constraints, and from there, figure out the best way to help the person change. So this requires health and non-health data for health and non-health actions. Now, compared to digitalization and integration, this is a relatively new area in HealthTech. But we do have a good example of applied contextualization from a couple of years ago. It is a project which involved IHiS, MOH, and all 3 clusters. It's the hospital-to-home program. The project was about figuring which inpatients might have greater risk of readmission and to apply targeted interventions to prevent a readmission. This involved applying AI to decipher data patterns and generating risk scores for the inpatients. The risk scores are based on individual conditions. And based on the risk score, the ground teams apply appropriate intervention to prevent a readmission. So it's about contextualizing the patient situation and applying very targeted intervention programs. We had most of the data, actually, technology foundation and data science experts to realize the use case. But it took many parties to develop the use case. it was quite an extensive use case as it covered from admission, to the hospital, to care at home and the community. What mattered a lot was that the use case was very well defined, and that enabled the technologies to enable the use case. So IHiS contributed the data scientists and technology expertise. Clusters contributed clinical operations and administrative expertise. MOH co-led the project and provided health economics evaluation. So the combined team of technical, clinical operations, and administrative professionals defined and realized the use case. It took a village to realize the use case. But there are gaps. Even though it was a good project, we have substantial gaps in contextualizing. Number one, our current segmentation is largely limited for episodic management. So when the patients turn up for a certain treatments, we are able to actually utilize certain risk profiles and scores to actually select the best treatment option. But we haven't quite applied it at scale in terms of disease prevention, especially primary prevention. There's also substantial data engineering overheads right now for such projects. There are gaps between data and the data standards, and we are short of data engineers. We need to go beyond providing risk indicators to actually using the risk indicators in integrated workflows. So in the H2H example, the risk indicators were provided to care assessment team's IT systems, which was also used for intervention program enrollment. So this allowed the use of AI information, right, in the actual operation workflow. It's also useful to recap the sort of data that we have. IHiS feels pop health requires 5 sorts of data for effective population profiling. Phenotypic data. I think over here is quite rich, especially our public healthcare data. On the side of non-health, like lifestyle data, I'm looking at HPV's very popular National Steps Challenge program and its smart collaboration with Apple and Fitbit. I think we are trending our data in the right direction over there. We also need social economics data. We are really rich over here. Within MOH, we have household database, and social government agencies are generally quite well digitalized. In the area of prompts and prems, this is relatively new, but I know all 3 classes are working on this area. And genotypic data. It's a relatively new area as well, but we actually have a very clear roadmap to genome sequence from 10K to 100K and to 1 million of our population. So we do have a fairly good data foundation and with good sound plans as well to scale up the richness of data across these dimensions. So after digitalized integration and contextualizations, it's actually at the end of the day, it's about engaging the citizens to adopt health-enhancing behaviors. From the tech standpoint, it involves empowering the citizens, facilitating access, and it's about providing information and interaction at the right time and with the right device. I think we have a decent foundation. We make significant progress in population apps. HealthTech is one of the most used healthcare apps in the country. The last I checked, it was also highly rated, 4.6 out of 5 in the Apple's App Store. It provides a cross-public healthcare view for the patients and the population. And for cluster-specific interactions, some patients use cluster-specific apps such as HealthBuddy and One NUHS. And NHG is building one app as well. IHiS has also developed a remote monitoring app for key vitals. We are working closely with MOHT to deploy this across the 3 clusters. This enables patients to conveniently track and submit their vitals to care team in polyclinics or SOCs. We see rapid adoption in the coming months. I mentioned the National Steps Challenge earlier on. I think before COVID, I think we were having more than 25% of Singaporeans on the program. So we actually have decent share of lifestyle data in the population. MOHT has also launched the myline.sg app in partnership with IMH and other social sector agencies. It serves as a one-stop portal for improving mental well-being or finding support. And HPV has partnered with private sector tech like Apple and Fitbit to nudge patients. I think this is a fantastic idea. There's only so much our own developed apps can reach consumers. because they are not, after all, they are not the pervasive apps or devices that we use. Consumer apps such as Apple Watch or Fitbits or even WhatsApp, Facebook and so on are much more pervasive, and they know so much about the users. We should really seriously explore collaboration with consumer tech companies, right, on how to actually nudge patients for health-seeking behaviors. Our apps can evolve further. Right now, apps such as Health Hub provide lots of useful information, but it is not a health companion. For the population who are motivated to achieve good health, we can increase the richness of digital engagement. They are already converted, so let's try to digitally empower them. For the unmotivated, we actually have to go beyond digital channels. We have to leverage all touch points. And for the underserved, we need to reach them through partnership with social and community agencies. As for the well-served, it's about right siting and service integration. So in closing, we actually have a moderate level of digitalization. We have a patient-centric NHR foundation, and we have high ability to integrate systems. We have good data foundation and well-adopted consumer ads. We need to close up a number of gaps. One is the digitalization gaps in terms of the breadth of digitization, especially in the private and VWO sectors. We need to increase the NHR contribution. We need to add in population health features for both public and private health actors. We also need to scale up targeted intervention programs and overcome data sharing issues. And finally, the quality of technology solution depends on the clarity of our care model and use cases. If we can achieve that clarity, the techies will figure out how to enable them. And the technologies are committed to work with all healthcare professionals and administrators in developing the care models and the use cases. I look forward to working with everyone, and my team looks forward to working with everyone on developing the care model and use cases to support pop health. Thank you.